Good evening, everybody. My name is Ed Lamontagne. I'm the chairman of the Simsbury Aging and Disability Commission. It's my pleasure to welcome you all to the third and final of our educational event series called Living Longer, Stronger, Advocating for Your Healthcare Needs. This evening, we are going to be discussing the impact of medication management on chronic diseases. And it's my pleasure to welcome Ruth Kalish and Brian O'Neill. Let me introduce Ruth first. So Ruth graduated from the UConn School of Pharmacy in 1998. Since 1998, she has worked in various staff pharmacy positions, including retail pharmacy, long-term care, a psychiatric facility, a rehab facility, and now currently in hospital pharmacy. She's been working at the UConn Health Center since 2003 and the investigational drug pharmacist there since late 2005, working with industry and investigator-initiated studies. In addition to being the investigational drug pharmacist, she also serves as the medication safety pharmacist since 2013, being the preceptor for UConn Health Center pharmacy residents and UConn P2 and P4 pharmacy students for approximately 6 years. As a preceptor for P4 pharmacy students, there has been involvement on various projects, including the initiation of CHF medication counseling by pharmacists, medication reconciliation projects, and other initiatives looking to decrease hospital readmission rates and prevent patient harm. In 2014, Ruth was awarded by the UConn School of Pharmacy as Preceptor of the Year. Brian O'Neill. Mr. O'Neill is a graduate of the Albany College of Pharmacy and has been providing pharmacy services for seniors for more than 25 years. He has held positions in long-term care pharmacy operations and clinical consulting for both small local pharmacies and large national LTC pharmacy providers. Mr. O'Neill is the owner of Prescription Associates, a company that provides clinical pharmacy consultants to long-term care nursing homes and assisted living facilities. He is a fellow of the American Society of Consultant Pharmacists, board member and past chairman of Commonwealth Medicine's Mass Health Drug Utilization Review Board, and former member of the Pioneer Valley Hospice Professional Advisory Committee. As a consultant pharmacist, Mr. O'Neill has presented many educational programs to LTC nurses, assisted living residents, as well as various community groups, including Parkinson's disease and Alzheimer's support groups. So it's my pleasure to welcome both Ruth and Brian. Thank you both for being here. And I start with Ruth.
So obviously probably the first place to start is when people come into the hospital. As he was saying, I've been a pharmacist there for about 13 years. And a subject that's kind of near and dear to my heart, called medication reconciliation, and we're going to go over a little bit of what that entails. So first of all, I have no financial conflicts of interest. The objectives, or what we're going to discuss over my presentation, was going to illustrate the process for obtaining medication history upon admission. I can't stress enough how important medication history is when people come into a facility such as a hospital. Define what is the best possible medication history. Review a case example, in particular, where having so much information about what medications people are on, it's hard to find what's the truth of what people are taking when they're at home, and how to get engaged while you're in a facility such as a hospital. And a facility could also, not just for a hospital, but it could be when people are in a rehab facility. It could be when people are in a long-term care facility, in an assisted living facility. So you really have to be engaged in your care wherever someone may be, if you have someone else that's taking care of you during that time. So what happens when people get admitted? For the pharmacy end of things, we always think of how things with medications work, because that's what we care about. So we want to make sure we obtain the best possible medication history, and I'm going to go through the details of that. So that's usually what happens at admission, and that happens through a few different ways, such as patient caregiver interviews, medication lists, vials, and then what happens when you get to the hospitals, that's what is used to order medications while you're here at the facility or at a hospital. And then discharge is when they take all that information for everything that happened at the admission point, what happened during your stay at the facility, and then they kind of wrap it up at discharge, and they send people home with a packet of what medications they're supposed to take when they do leave that facility. We have a kind of a statement and kind of what we use between us as pharmacists and actually some of the medical house staff. It's that garbage in, garbage out approach. So if we don't get things right from admission, things won't be right at discharge. So it's really important that people are engaged in the process, especially when it comes to medications. So there's a couple definitions I'll go through. So everyone thinks medication history. Medication history is just a preliminary list of your current or recently discontinued medication. It's a very kind of skeleton list, an outline, so to speak. A best possible medication list is a much more advanced medication history. We call it best possible medication list because we want to really get into all the nitty-gritty. Because when people come into a facility, that provider may not know your care, may not know your history of what you've been on, and often people may forget certain things that they take at home. We always say it's like the Dr. Oz effect. People are on medications and they don't realize, hey, I've got that shoebox of stuff from Dr. Oz told me some herbal stuff that really works really well that I keep, and people forget about that stuff. So, you know, that's why we really want to get to as a most comprehensive list that we can. Then there's what they call medication reconciliation. So someone will gather that medication list, get the best possible medication list, and medication reconciliation is basically the comparison of what you were taking out of that facility and what you're going to be taking when you get into a hospital or a facility. So it's that comparison, and the doctor's supposed to indicate, I don't want to continue this, I want to continue this while you're here, that sort of stuff. So and medication reconciliation is really critical to making sure when people do come into the facility they have quality care. Most hospital stays, I know at our facility, is about 4 days. So, you know, in just 4 days, a lot can happen. So we want to make sure we do as best of a job as possible. So this is actually a picture from a home in which they went in after the family member had passed away. A lot of people get those automatic refills. The automatic refills are just a way to prompt people to, you know, get stuff renewed. However, as we see, you tend to accumulate stuff. And when you accumulate stuff, it gets really confusing. It gets confusing for us as pharmacists if someone brought this to me to try and figure out what you're taking at home. So that's one of the things that can make it very complicated to get the best possible medication history, because just because someone had it filled at the pharmacy doesn't mean they're taking it at home. You know, a lot of people, when they do have a prescription called in, they may go and pick it up and be like, no, I don't really need this, or but let me just keep it in the closet just in case, you know, it comes back, just in case I need that pain medication, and then it gets really unsafe. But for us, it makes it difficult to figure out, well, what are people really taking at home? The list we want at admission is what you actually physically take at home, because it gets really confusing. In order to give people the best possible care, we need to make decisions upon what they're taking in that time period right before they come in to a facility. So, as I was saying, the best possible medication history is a really comprehensive look at what people are taking at home. And it can involve not only talking to the person who is being admitted to the hospital, but a lot of times, sometimes people aren't feeling well, so family members are sometimes talked to, or maybe they have a visiting nurse that comes in to take care of the patient's medications, and often we'll have to go to that person to get a list. And ask for their input, or usually they have a list that they can provide to us. But that's why we always say it's really important that your family members should know what you're taking at home, and they should be able to access that information in case there's an emergency. Rather safe than sorry. You know, there's medications we could give in the hospital that could interact with what you're taking at home, and we don't know what we don't know. So if we don't know you're on something, it can really be harmful. And usually we want to verify it with multiple sources. We have the ability, it's kind of neat, When you get into the hospital, we have a system in our computer in which it actually brings up your insurance claims through your prescription. So we can actually see what's been processed through the insurance for your medications. So that's often something we'll look at to see, what medications you've had filled in the past. And it may not have all the information we need. Maybe the directions aren't there. Maybe occasionally a dose isn't there. But it's really a useful tool for us. But we always want to verify with 2 sources to get that best possible medication history. So it could be, like I said, that interview with the patient. It could be the information we gather through the insurance claims. Medication prescription bottles are always handy. They're right there. Patient medication lists. But I often do say you need to keep those lists up to date. We had one patient recently who admittedly, after kind of getting, we had to talk a few times. One of the pharmacy techs I work with finally admitted he hadn't updated the list in about 5 years. So they were actually ordering medications based on a list from 5 years ago. But he felt embarrassed. I mean, we find as pharmacists that people will admit stuff to us that they may not admit to the doctors. It's just, I don't know, we're kind of like on a different level, different playing field, but usually we'll find out stuff that they may not want to tell the doctor because it's embarrassing. You haven't been taking your medications as you were told to take them, or so that sort of stuff. Medication profiles from another facility. If someone comes from another place, they'll come with a medication list, and obviously that would have information would need. And then as well, anything that's already in our system. If someone comes to UConn and they go see a doctor there, that information is stored electronically in our electronic medical record. The only thing is, those electronic medical records are just getting bigger and bigger and bigger and bigger, and it's very difficult to get the source of truth. It's a great idea that everything's computerized now, but to sometimes find that little detail, like one little thing you want to look for, you're searching through a whole bunch of different records. And a lot of the records are very repetitive. It's the same type of information over and over again. And sometimes the medication lists are wrong and you're trying to figure out stuff. So computers are great, technology's great, but it brings a different level of stuff and errors that can occur. So essentials of a best possible medication history, these are just some of them. And like I said, people forget. They get that Dr. Oz effect. You've got stuff sitting in a shoebox that you're like, yeah, I take that. People forget. Maybe they go to their doctors and you have an injection there once a month, or they go to an infusion center and they have something infused. People forget about that stuff, but that's medications that you're on. You go to the doctor once a month to get that medication is in your bloodstream the entire time. So, those are the things we want to know about when we're trying to get the best possible medication history. Medication pumps. People often forget about them. Sometimes people have insulin pumps, or they could have pain pumps that have pain medication in them, so they're constantly getting pain medications infused through, some sort of like an intravenous or like subcutaneous under the skin pump. So people often forget about a lot of things. So we often will use what they call open-ended questions. Usually I've had patient interviews, I have students with me, and they'll go in and they'll just read a list to a patient and be like, so you take this for your blood pressure, that for your glaucoma, and the patient's like, yep. And I remember one interview and he's like, so what do you think of the weather today? And the patient goes, yep. So people just agree with what you're saying. So you really have to ask, like, do you take anything topical? Do you know anything, like any creams you take? You want to ask questions that are, what type of product do you use? You want to ask questions that are probing to get a little bit more information, because it's overwhelming when people come into a facility. People are sick, they don't feel well, they've had, I work in an academic facility, and the doctors all travel in these groups, these herds of, a whole team, and people come in, and it's overwhelming. So, we want to ask good questions so that way we can get information for when people are admitted to the facility. So, who can take your best possible medication history? It can be a multiple of people. It can be a pharmacist like myself. It can be a provider, so that's like a doctor, an APRN, or physician's assistant. It could be a nurse. And then what we use at UConn is we use pharmacy technicians. So we have pharmacy technicians that are trained to go and meet with patients, and their primary job day in and day out is just to get that best possible medication history from patients when they're admitted to the hospital. It's a useful tool, and it's actually a huge cost savings, because for one of me, we can get 3 of them. So, you know, and they're able to do, there's been multiple studies, they do just as good of a job as a pharmacist. Because you can imagine, if your job is only that job day in and day out, they know the tricks. They know the local pharmacies and who to call and who can help them out, find out some information. You know, they start to, you know the tricks of the trade, so to speak. So we're really proud of our program by using pharmacy technicians, and we've significantly decreased the harm that can result from getting a poor medication or a poor best possible medication history. So medication reconciliation, like I said, if you don't, it's garbage in, garbage out. So if you don't have a good, solid, best possible medication history, you may not get the medications that you need ordered while you're in the hospital or facility setting. And the most common is the omission of a regular medication. And they can be really important medications. I've seen stuff like if someone's a diabetic that they didn't order insulin on the patient. So those are really critical medications that can impact how a patient does it at the hospital. And the predictors of, you know, certainly having a medication reconciliation event in which there's gaps are age, which is, you know, makes sense because people get older, they're on more medications, multiple medications. When you start getting on more than 5 or more medications, there's a higher risk of mistakes that can occur in multiple providers. That's where, as well, it gets a little confusing because patients may go to multiple people and they may be ordering stuff that the other one doesn't know about, that sort of stuff. But those are usually predictors in which patients will have more of a trouble when they're in the facility or hospital setting. And certainly, as I'm saying, you know, incorrect medication histories can result to adverse events in the hospital or even following discharge, because it's that garbage in, garbage out. So if we didn't get good med history, we didn't order the right meds while people were here in the hospital, they don't get the right med list when they leave. So it's really crucial, the whole process. So this was an example that I used because it was something, it can be very time consuming for some patients to really figure out what they're on. And it just gets more and more muddled. This was a patient who had heart failure, multiple other disease states, legally blind, and she counts on her husband to take care of all of her medications. And so what sources could we use to collect a medication list? In the next slides, I'll show you just some of the problems that we ran into. So these were just a few of the medications the patient was on. So a medicine outpatient note had different information than the cardiologist had. The pulmonologist had different information than the cardiologist and the medicine doctor the patient went to saw. And then when they came to the emergency room is getting different information than those. And then what we had gotten when the patient came in. So it's really confusing. Some of these medications, like this is furosemide, which is Lasix, is a really, really important medication for heart failure because it's your water pill. It's going to get that fluid off. So you would think my cardiologist would be like, yeah, I'm on Lasix, you know, I'm supposed to take my furosemide. But the cardiology didn't list that the patient was on it. So it just gets, you're like, what's the source of truth? What is the patient really on? And then we call the pharmacy and it gets even more confusing. So, you know, what really is the truth? You know, there's, you know, furosemide, we saw that Lasix, that water pill, had been recently filled. One of the other medications hadn't been recently filled. You know, one medication, this last one, metolazone, which is another medication that's important when people are of heart failure, it was filled 7 months prior. So it's really difficult, and unfortunately the husband really couldn't provide the information because he just took the bottle and he filled up the pill boxes. And, you know, it's really, you wonder if that's the reason the patients come into the hospital. And that's probably part of the reason. They went into their heart failure got worse. Maybe they weren't taking the medications. Maybe they weren't taking this one like they should. And then, but it's really hard to figure that out. And sometimes people, you remember the show like Dr. House and, and all those stuff. Like sometimes people look for when they, providers look for when people come in the hospital, they look for the really complicated stuff. They're thinking it's going to be a Dr. House situation. As a pharmacist, what I see is non-compliance, like people not taking their medications appropriately or how they should be. I've seen that happen more than other factors. So, I look for the simple stuff. It's always that KISS principle, keep it super simple. So while you're in the hospital or an inpatient facility, this very simplified way to kind of break it down is provider work writes an order, so that could be your APRN, a doctor, physician's assistant writes the order. The facility pharmacist processes it. So myself, I'd basically electronically validate the work that the provider has put in, call them if there was an issue or anything that I saw was didn't make sense. And then lastly, once I validate it, you kind of release it and the nurse can administer it. So it's really important that you realize there's rights of medication administration that nurses are taught. And I think it's important that people should realize when they do come into the hospital that they should know it used to be the 5 rights of medication administration. I think it might be up to 7 or 8 now. But these are the things that nurses need to do every time they give you a medication. We have a lot of safety features in the hospital, such as what they call barcoding. So all medications come with a little barcode on it. And patients get a little barcode on their little wrist when they come in. So before they give medications, they barcode the med, they barcode the patient to make sure that that's the right patient. However, as we know, technology doesn't always work. People can still bypass stuff. People can override it. But this is to help with some of those rights of medication administration, such as right medication, just like that barcode. Am I getting the right medication? Is it the right dose? Is it the right patient? That's happened. We used to have, in the hospital, you'd have an A side and a B side. You'd have one on one side, one on the other side. We've had instances where the nurse gave the meds to the A patient, but it should have been the B patient. Stuff does happen. So is it the right time to give the medication? Is it the right route of medication? That means, was it supposed to be intravenous instead of orally, or taken by mouth? Right documentation. When the nurse administers a medication in the hospital, especially something as what we call PRN or as needed, they're supposed to document the results of what happened after that administration. Right reason. Is it given for what it was intended for? In right response. It's really important, some of these things. We see things and, stuff happens. But, when you look at studies, this is one that I brought up. This is a 2009 study where they talked to people that were in the hospital, and 96% of them failed to recall 1 or more medications that were prescribed during that stay. That's really alarming, that they don't know what they're taking. And on average, patients omitted about 6.8 hospital medications, so they didn't know about 7 of their medications that they were taking. And only 28% reported that they had been able to see what they were getting at the hospital. And 94% obviously felt that review of the hospital medication list has the potential to prevent errors, to reduce errors. So, it's really important that people get engaged while they're in the hospital. And you have every right to ask them what they're giving you. It's not, people have a right to refuse medications, while you're in the hospital. But you have to ask. And it's really important that people do. Because errors do happen. As a medication safety pharmacist, my job is looking at medication errors that happen in the hospital and doing what we call like a mini root cause analysis. So we try and look at the root of the problem to see what could be done to fix it and make sure it doesn't happen again. Now, we don't blame people. It's not, people don't go to work and go, I really want to hurt someone today. That's not what we do. As a healthcare provider, I go to work every day and I try my best to do the best job possible. But errors do happen. And a lot of times it's what they call system gaps. When we have an error that happens, we always ask the question why 5 times. Why did something happen? And usually it boils down to there's something wrong in the system. whether it's a policy or perhaps communication, just as common causes of medication errors, or performance or knowledge deficits. People don't know what they don't know. We've seen errors that occur because the nurse didn't realize something, or maybe the doctor didn't know something. We can't be expected as, a healthcare professional. I certainly don't know everything off the top of my head. And it's really important that you as a patient, or when you come into the hospital, you're engaged in it, in the process, to realize that errors can happen. And what type of errors that occur? Wrong dose, wrong drug, wrong route of administration are some of the more common ones that do occur while people are there. We don't want errors to happen. We really don't. And we want to make sure it's as safe as possible when people come in, but it's sometimes we just can't prevent certain things from happening. But certainly, like I say, let's all work together for safety. We want to engage people because the prescribing medication is the most common intervention when people come into a facility. When they come into the hospital, first thing they do is they order a medication. It's usually, maybe they order a procedure, but usually medications are sometimes the most commonly, whether it's an antibiotic for someone's infection, pain meds because maybe they broke a leg or something like that. So usually it's the most common intervention is medications. And so you want to ask what your medications are for, ask what side effects to watch for, know the names of the medications you get and what times you should get them. Any container that is brought to the bedside should have a medication label on it, and you should ask what medication you are being given. It's your right to know what you're being given, and it should be labeled appropriately. Because what if they took like that A and B patient, they took all the medications out of the little, little packaging, and they put it in a cup, and they didn't bring it to the bedside with the labeling. It could go to the wrong patient, and stuff like that happens. And speak up. I'm just surprised. Some of the errors that we do find, the patients knew it was wrong, but they still thought, well, I don't want to ask. But if you speak up, you're engaged in the process, and sometimes we found the patients are just as good of sources of information than sometimes us as healthcare providers. I saw one patient, I don't know if anyone's on something like warfarin, but warfarin's a blood thinner, and this patient was ordered it, but she had stopped taking it a few months ago. And we had someone go in and talk to her and counsel her about warfarin, because we thought she was just supposed to be continuing on it. And she's like, no, I stopped it a couple months ago. And she's like, I knew I shouldn't have taken it last night, but I just thought they knew, but they didn't know. So we had to go back, and eventually, they talked to the patient and stuff like that. But she had that nagging feeling, I shouldn't take this, but she didn't speak up, and we really want people to speak up. So that's what I say. When in doubt, speak up. It really, you never know what can happen, and we want everyone engaged in the process. There's a lot of initiatives for this, more of a safety culture within the hospital setting, because we realize how many errors can occur in the hospital. But we all want to be kind of a process together, and stuff, as I said, like getting medication history and how important it is to make sure we have the right medications through admission can really make a difference. So, and then I have a whole bunch of references that I'm sure everyone's going to read. But anyways, I'm going to turn it over to Brian here. So he's going to talk about what happens after you leave.
All right, let's see, part two here. Okay, so Ruth pretty well covered what's happening in the hospital, but then what happens when we get home? And I think that you saw all the medication errors that can occur in a hospital when you have all these professionals around you, right? Now we're writing all these brand new prescriptions for you. You're going to go home with those, and I love that picture because it happens. I have a story about a family member who asked me to help them with his medications with my wife's uncle, and I went through. He just came back from the hospital, and he asked me to come in and help him out, and I was there for 4 hours, and then I found out he had a drawer similar to what Ruth showed you. And I said, Uncle Norman, you got to get rid of some of that stuff. He didn't, you know, he said, I already paid for that. Well, we're going to talk about that in a little bit. So, I also have no financial disclosures, but I do have one disclosure, is that I went to the free library up the road here a little bit before I came here. So that's the only disclosure I think for today. For the objectives, that transition from the hospital to home is a very, very important one, and that's where we see medication problems occurring. I work primarily in nursing homes, and we see difficulty in that transition from the nursing home environment to the home, from the hospital to the nursing home. So in these transitions of care are where errors can occur, and we want to try to minimize those as much as possible. And I think it's important to understand what some of the problems are and what some of the problems can be, and then mostly try to avoid them as much as possible. And I want to give you some real simple, not real complicated things that you can do to minimize those potential problems. And then last but not least, I actually, this one I like, to help make your next doctor's appointment an enjoyable one. Now, who really enjoys going to the doctor? My doctor is actually a personal friend of mine, and we talk more about his crappy golf game than we do about anything else. You know, but that's a whole nother dynamic. And when you go and see your physician, I've seen statistics from anywhere from 6 to 12 minutes is what they spend with you. Okay, and then you get the prescribers, the extenders, the nurse practitioners, the physician's assistants. Okay, and you get very little time with your doctor. There is a strategy to get as much time with your doctor as you could possibly want. If you show you're interested, he'll be interested in it as well. Okay? So I just want to take a quick survey too before I really get into the nuts and bolts of this. How many are here to kind of think about managing your own medications? How many are here for helping to manage medications for a loved one or a friend? Right, the pill boxes, right, those kinds of things, okay? I think we're going to give you some pretty practical solutions that you can bring with you. So what I really thought about when Lorraine asked me to come here today and to talk to you, I mean, I love this stuff because this is what I went to school for. And I work with elders, and I see the problems that when these medications aren't managed, then I see these folks in the nursing home, okay? And the number one reason for people to go to the hospital, go back to the hospital for readmissions to the hospital, are medication errors, okay? So it's vitally important that we manage these prescriptions, and for chronic diseases, we get more and more and more. And all the treatment algorithms that we learn about in school and the physicians are applying to their practice settings. It used to be you got 1 or 2 medications to treat CHF, congestive heart failure, or hypertension. Now there's like 5 or 6. And it's not incorrect, but when you're 90 years old, with 5 or 6 of those medications, can we get by with 1 less or 2 less? Okay. So when I was thinking about this, I thought, and just indulge me for a minute, because I actually was thinking about my dad, and we lost him a couple years ago, but the process that he went through to go from the hospital to go home, and it was long distance for us, but what the stories that I heard, mostly from my mom, not my dad, were, I gotta get the next slide. Oh yeah, here it is, okay. They're in the car, they're driving home, silence. Why? Number one reason is fear, okay? My dad was afraid of what is in front of him. He didn't know what was in front of him, okay? But the confusion about what happens, and medications is a real big part of that. That's, to me, what generates that fear. When you don't know, then, and my father was a pharmacist, by the way, right? So the medications that wasn't the tough part for him, okay? But it was the whole rest of the disease management that he had to go through. And my dad was part of the greatest generation. He would never tell you he's afraid. Those words never came from his mouth. And he would never tell you that he was confused. So I would call, and I'd say, he'd tell me what was going on, he'd tell me something, and I would just say, geez, that doesn't seem to make sense. Have you thought about this, Dad? Or, that's fine, just leave it alone, right? And he'd start yelling at me for sticking my nose where it doesn't belong, because he didn't have the answers, okay? So that's kind of what I was thinking when I started to put this together. So you get wheeled to your car from the in the wheelchair from the aide at the hospital. You get put in the car, and now you're driving home, and you're just trying to think about all the myriad of professionals that have come into your room to discharge you from that facility and to talk to you, but from nursing, physical therapy, pharmacy, medicine, everybody, and now you're totally confused, right? At least my dad was. So now what happens when you get home? So it's my mom and dad, and they call me, my two brothers. Once all those same calls are made, they got to make the rounds and tell us all what's going on. When my dad walked in the door, all he wanted was his favorite chair, his iPad, his book, and believe it or not, almost every time he came home, he wanted a grilled cheese, ham and cheese sandwich, and a glass of milk, right? That was home for him. That was comfort for him, right? So now, once he got past that, and now it's okay, now he kind of just mentally just says, okay, I'm home from the hospital, now we have to deal with what's in front of us. And they get out that packet that they give you from the discharge packet. I've had my knee done, I've had my shoulder done, and I had a packet like this, and I was fine, right? It's like this. And so you start going through all that stuff, and you say, oh, now what, right? It's a process, and there's folks out there that don't have you folks who are here doing this in here for somebody else. There's people out there who don't have someone who can do this for them. That's what scares me as a pharmacist. Because those folks are at home trying to manage these medications without folks like you being able to help them. Okay? So I guess really the theme for me would be that if we can take care of any of the confusion around not just medication, but the whole healthcare process, the more confusion we can take away, the less fear we're going to have. Okay? Okay. So now you open up that packet, and you get all these brand new prescriptions, and you've got all these other prescriptions that have been there for 5 years. Now you say, okay, you open up the packet, and it all starts coming back to, oh yeah, I got to do this, oh, this prescription's for that, that's a new one, that one's getting DC'd, and most of it's coming back, but not all of it. Right? It's a process, and you have to process all of this information. And again, that's just the medication side of it. The physical side of it is a whole nother ball of wax. Okay? So if I could make a suggestion, the first thing that I would ask you to do is have a list of your pre-hospital medications. So when you're home, now this is a scenario that we're coming home from the hospital, that we've already made a list of our medications. How many have a list of all their medications? Nice. Wow. All right. I don't. Right. Because, I'm a pharmacist. Why should I have to do that? I think, Ruth alluded to it with the pharmacy tech, right? I actually do, but it's buried somewhere deep in my computer, and I haven't touched it in 5 years, so I'm getting together with our pharmacy tech. But a list of the medications is all well and good, but I think it's important to have the dosage of the medication, and as well as how many times a day you take it. The more information you have on a list, the better off you are. Okay? So now what you do is you take your list of medications in that discharge packet and you kind of compare them. What's new? What's changed? What's been discontinued? And I know, I can hear you guys already, but the medications that have been discontinued, throw them out. Because you're going to get to the point where you get to that picture. Yeah, that's an extreme example. But Uncle Norman was the exact same way. He had more medications that were outdated, and I started taking them and started, I was going to get rid of them for him. Not a chance. Not a chance. So I think it's real important to make sure that you don't have all this excess medication. And then the other thing is, you have to keep it safe. If you have little children, if children or grandchildren that are in the house, you have to be very careful with storing the medications and making sure they're out of harm's way. Okay, so now the fun part here. How do you manage all of these medications? And I think Ruth did a really good job about telling us how in the hospital they try to elicit information from patients. But if you have a medication that you're taking every day, if you take an aspirin a day, right, that's pretty easy to remember. But when was the last time you took a Tylenol? How often do you take Tylenol? How often do you take Advil? Those are medications that can be very important and interact with other medications. So we need to know how often you take those medications, right? And it's also important to remember herbal medications. I just get that herbal stuff from the pharmacy, and I take that every day. There's a lot of those medications that interact with the prescription drugs. So it's important to include everything on that list. The other important thing to do is to write your list in pen. Do not use a pencil, and do not use an eraser. Right? You can cross it out, put a line through it, that's fine. But it's important, if Ruth ever needs to see that list, if you go to the hospital, it's important for her and her physicians in the hospital to know what you've been on before, what doses of medications you've been on before. And we don't need to go to the extreme of putting dates and stuff like that, which is something we would get in a computerized format. But if we're going to do something that's a handheld format, just writing down the name of the medication, the dosage and the number of times that you're taking it, and then put a line through it, and then however you're taking that medication after that, okay? It's important to have all that information. Now, let's see, keep a copy on your refrigerator. I actually got my mother to do this. She doesn't take a lot of medications, but I said, look, you live alone, and if anything ever happened to you, the first responders are trained to look on the refrigerator for a list of medications and any other pertinent medical information. So I've asked her to keep, a few copies in a sleeve, page protector thing on her refrigerator. And I was down there a few months ago, and so far so good. We'll see what happens. We'll see if she keeps it updated. The other thing I think is important is keeping a journal of not just your medications, but when you take your medications and how you feel after you take your medications. Now, I got to relate another personal story to this. And when you guys go into the pharmacy now, it always hasn't been this way, but you get a arm's length list of all of the different side effects of the medications. So when those first came out, my Aunt Connie, God love her, first one on the list, well, if I take this medication, what's going to happen? Well, what they told me in pharmacy school was you say headache, nausea, vomiting, diarrhea, constipation, and then go look it up, right? So my aunt would take the pill, and she'd, what do you think's going to happen with this one? And she'd sit there, and I don't care if you told her that your left toe was going to start to hurt. Her left toe would start to hurt, okay? So we have to be able to separate reality from not reality. So it's important like if you're taking a blood pressure medication, put the blood pressure down if you're taking your blood pressure every day. Because what happens when you go to your doctor's office? How's your blood pressure? Good. Do you have any examples of your blood pressure? Well, it's right around 120/72, right? Ish, right? But if you have a list, you can give them actual data points. I think it's important. And the physician, that's what I'm talking about, where the physician, if you're putting time into it, the physician will put time into your health, okay? If you're a diabetic, and you can get these cards for your blood pressure. I think you can get them at pretty much any pharmacy. I think that they're available at the pharmacy counter. And if not, just ask them. I'm sure they'll get one for you. But you can keep a list of your blood pressures. You can keep a list of your glucose, you know, your blood sugars if you're diabetic. But the other thing is to keep track of subjective things, because just like I was telling you before with my aunt, that when you take a new medication, there might be some subtle changes, and you want to keep track of those subtle changes. And you want to say, okay, look, if you take a medication and you start to feel nauseous, is it that placebo effect? Is it something that you're talking yourself into? But if you take it and you're still feeling this, general malaise, I think is the right term, but if you're documenting that in relation to when you took the medication, then you have some real information for your prescriber, whether it's a nurse practitioner or physician, to be able to make either dosage changes or changes within the same therapeutic class of that medication. All right? So it's important for them to be able to make these subtle adjustments. So the last thing that I really wanted to talk about was how to make the most of your follow-up, because when you leave the hospital, you have a follow-up appointment. You have a follow-up appointment with your doctor. And it's usually about a week after. Is that about right? Is it about a week after or so, maybe 10 days? You have a follow-up appointment with your primary care physician. And that is that very first appointment after a discharge from the hospital is the most important, because there's been some significant changes that the physician really needs to monitor. So what I've asked people to do in the past is similar to that list of medications you have on your refrigerator. Just, you know how you got a list of things to do? Just have a list of things to ask the doctor. Now again, my doctor is a friend of mine, right? I go into his office, and I'm not kidding you, we talk about his golf game more than anything else, which is fine with me. But I'll be driving home, I was supposed to ask him about this, that, or the other thing. Right? I'm healthy, there's nothing, no big issues or anything else like that, but if I forget, can you imagine somebody who has all these chronic issues that they were in the hospital for 4 or 5 days with? Okay? And they're going to miss something. So write it down, and then you won't forget to ask the physician. Make sure you bring a copy of your medication list and that journal that I was talking about. All of those things, to me, you can stop the doctor in his tracks, because we all know that they're in a hurry. They have to see a lot of patients, and they will take the time when they need to take the time. They're the ones who decide if a patient, if they need to take a lot of time with somebody who's a brittle diabetic, they will take the time for that patient, and they'll let the office back up because that patient needs them at that point. But it's the routine stuff they're just going to kind of go through really, really quickly. But if you have all this information and you sit down with your doctor and say, hold on a minute, can we go through all of this? I'm feeling this, I'm feeling that, I'm on this medication, I'm on that medication, this has been changed, that's been changed. They are going to take the time to sit down and walk you through all of these issues. Or at a minimum, they'll have you sit down with their nurse practitioner or their physician's assistant if it's something that he doesn't himself have to deal with. But you'll get the attention that you need when you have the information available that's going to allow them to help you. Okay? So the last thing is that don't be afraid to ask questions. Be prepared to ask questions. Okay? They want to spend time with you, and they will. All right? So speaking of questions, yep. They never will, because they want to. Oh, okay. Lorraine asked if you know, how do you get the physician to that point where you know, you can ask them to take the time to spend with you. And I'll go back to what I said earlier. They want to. They really, truly want to. But if like anything else, I mean, you know, when I go to work, things can be routine. Okay, and there's no different with a physician or a nurse practitioner, or, you know, we're all human beings. Things can become routine, and then when you say to the physician, look, I've got all of this information, which is more than this generic sheet that he has. Now you have real live information, and I think that they're more than happy to help you with that added information. And you're never going to get rebuffed. I don't believe. I mean, I haven't had to do it with my primary care. I've had to do it with, you know, some specialists that I went to see, and I just said, hey, look, I know you're busy, you know, but this is the only need. I only got one other one, so let's talk about this and let's figure out, you know, what's going on and why I have to have the surgery, not to just schedule the surgery. And you're right. I'm already behind today, and he took 10, 15 minutes just to, you know, talk through that whole process. They will. They truly will. Yes, sir.
One of the confusing things is the non-medication interactions.
Yep.
Alcohol, grapefruit, the grapefruit juice thing.
Yep.
Take it with food.
Yep.
You don't have to take it with food.
Yep.
And sometimes those aren't specified. There's just a little label on the bottle that you can easily miss.
Yep.
What is the grapefruit thing, by the way?
Well, it's an enzyme that the grapefruit juice has that it doesn't allow for. Oh, I got to repeat the question. Sorry. The question was, you know, the subtleties of the medication side effects and how to take it correctly with food, without food, with cranberry juice, without cranberry juice. And I always just say, look, take it with water, and you're not going to go wrong. Right? That's just the easiest way to do it.
So the grapefruit has an enzyme that...
Yeah, well, and what it does is it prolongs the elimination of some drugs. Not all, just you know, there's a very, very small number of those drugs, but they're important drugs.
Yeah, I just wanted to chime in and say a lot of it is everything's moderation. You know, when we talk to patients, especially about something like warfarin, we're like, avoid leafy green vegetables. And people are like, oh my God, I'm never going to eat spinach again. So it's really everything in moderation. You know,
Good point. Yeah.
You really have to just maintain what you're doing every day. And I'm like, you're not going to go out and be a rabbit, right? We're not, you know, going to be grazing the grass out there and stuff like that. You're going to be okay. But it's everything in moderation. I think people, it's nerve-wracking when you get a lot of these medications, you get all these little labels, and those labels on the bottles are like, I don't know, you really need like magnifying glasses to read them, you know? So it's really difficult sometimes to get that information. And I just wanted to say for the first comment too, is us as pharmacists, there's programs out there where pharmacists, you can get one-on-one counseling. It's called medication therapy management.
Yep.
We're unfortunately not by the United States of America recognized as healthcare providers by CMS. So we're not recognized as such, so we can't get reimbursement. So there are ways to get money for our time and services that we perhaps go and counsel, or I'm not talking about at a CVS or Walgreens, but actually in a doctor's office setting. And often it's difficult for us to get reimbursed for our services. So I know through the School of Pharmacy at our facility, in the medicine clinic, they actually have a pharmacist that, as well as part of the doctor's visit, you meet with a pharmacist or a pharmacy student. And that's really helpful because you get extra time with someone else to discuss what medications you're on and find out about the grapefruit juice or how much green leafy vegetables I can eat and that sort of stuff. So I'm always like, we need more people to support having us as pharmacists be recognized as healthcare providers so we can get reimbursement. Because I think if every doctor's office had a pharmacist in there, I think it would be, for me, I'm like, yay, pharmacy. But I think we could really make a difference because doctors have to think of the whole world. We just want a piece of that world.
Right, and I was just going to say, yay, pharmacy, but you know, what are the things that get people in trouble? Yeah, it's the medications, and it's not managing the medications correctly that gets people to see Ruth in the hospital.
Yeah, you don't want to see me. But yeah, it's really, you know, supporting what we do as pharmacists. I think pharmacists are some of the most enthusiastic people about their jobs. Like I find that when people become pharmacists, they really, you have to have strong people skills, and everyone's type A personality. To read all those prescriptions, you really had to devil in the details. So.
Yep, that's very true.
I just wanted to say thank you for this file of life.
Yes.
And it came from the school, from UConn School of Pharmacy.
They like at the NBC Connecticut, like they had a health fair, and the students will actually, like they have a computer program, and they'll type out those file of life. And those are really important, like he was saying, to stick on the refrigerators and stuff like that. But
Well, we carry ours, we have one on the refrigerator and
Yep.
one on the wallet.
Yep.
So,
yeah,
yes, it's great.
Good for you.
Wonderful.
Yep.
yeah.
Thank the School of Pharmacy.
Yeah, no, the School of Pharmacy, it's great, you know, to have students.
Thanks for listening to our suggestions too. I mean,
Thanks for being the example for everyone.
yeah.
So, does anyone else?
Point about the doctor and time spent. One of the things that I see with some of my clients is that people have to recognize an advocate for themselves.
Yep.
They just don't ask the questions that either they said earlier, fear, but in order to do good medical management, you have to advocate for yourself, because you know yourself best of all.
And you have to have that information to be able to advocate for yourself, and that's I think it's real simple, but you know, how many people have that journal? You know, how many people keep track of their blood pressure? I'm sure that there's plenty of people that do, and if you're diabetic, I'm sure that there's, you know, a lot of diabetics keep track of their finger sticks, but you got to bring that with you. You got to present that to the prescribers. They want that information to help you to better manage. Yep.
The other thing I say is we have somebody for over people,
Yes.
especially for elderly people.
Yep.
Yeah.
Because if the doctor says something you don't expect, you hang on to that, and they keep talking about something else, and you're still back on, they found my blood pressure. Oh, I didn't know that, you know.
Yeah, even in the hospital setting, I think it's really important that you have someone that's involved in your care. You know, whether it's a spouse or a child or someone that really knows everything. Because if something happens to you, you want someone else to have some information. It's scary for the people that don't have that support out there, that caregiver support. It's scary when we have those people come into the hospital setting because trying to find out what they're on or what they're taking at home, it can be difficult.
And that's why I applaud you folks for coming out on a rainy night to get a little information, and that really means a lot. You care about the folks that you're helping with those medications, and it's very, very necessary. It will definitely decrease the potential for any kind of untoward event with medications. The more you learn, the better you're going to be.
Sure.
In regards to what you said earlier about the fear factor in the hospital, having been, I don't know, years ago, in the hospital for years and being a nurse, being surprised at this and the issues surrounding medication and the doses and the things that go. And I remember at midnight thinking, I'm not going to work. I'm afraid of this blood flow. I remember reading the diary and I said, "How to say it?" And I went, "Just take a chance. You'll be fine. You're going to come down." And then she went and left there and started walking. And it was left a while.
Yeah.
And I could go in there, but I was certainly really pretty interested, because she had a very bad life. And I'm a nurse, and
Yeah.
I'm fairly,
It's really, it's, I think it's scary for people when they come in the hospital. And there are herds of people. They're like, I work in an academic facility, and the doctors just travel in herds. They're like, because usually on a medicine team, for example, you could actually have up to 5 or 6 people on one team that's taking care of you. So you'll have what they call your attending, your hospitalist. You'll have a resident. You might have a couple different residents. You might have a medical student. You'll maybe have one of my pharmacy students on this team. You could have, an APRN on the team. So when they go in round on everyone in the hospital, they like travel in packs. So, and a lot of people when they've come into the hospital have commented how intimidating it can be. Can you just imagine you're like in the bed, you're so vulnerable, you're wearing this gown, you're like, I look horrible. And then you've got like this whole herd of people like going, hey, what's up? How you doing? Like, and it's difficult sometimes to, ask questions or, sometimes they don't mean to, but, when they're together, they're teaching and they may be talking about you in front of you. And it's embarrassing. I mean, I feel embarrassed, and that's sometimes intimidating to speak up. Yeah. And that's absolutely, yeah. Yeah.
they come in, it's like an audience, and I'm like, there's no way.
Yeah, and absolutely. Yeah, and absolutely. That's what I think people need to realize is they can refuse anything in the hospital. You can refuse a medication, unless you're there committed, for a psych facility, it's different. But, when you're there, you're not there under your, under duress. We're not, you're not shackled to the bed here. So, people need to be engaged and ask questions and feel comfortable to go, I don't really feel comfortable with all these people in the room. I mean, I felt embarrassed. Like, I remember I went to a dermatologist and I'm like, they're like, oh, we were going to bring in all the students. And you're like, can everyone leave? So,
If you'd have told me before I came in for the appointment, then maybe you could get yourself
I would have
prepared for it.
rescheduled.
There you go.
But, like, that's what I think people don't realize. They need to be an advocate for themselves. You really need to speak up because it really is scary. I see it, you picture yourself, how would you feel in that bed and how, intimidating it is. And, we don't mean to be that way, but you just forget about it. Because for us, like you're saying, it's routine. Like every day we go in with the team, we go and see the patient, but for you, it's not. If you're here in the hospital bed, you're like, this is my first time in here. I'm really scared. My dad had Alzheimer's, and I just remember how much of a situation it was, because when someone has Alzheimer's or dementia and you bring them into a new facility, we went into the hospital, routine was gone.
Yeah.
So it was just, my dad did not do well in the hospital, and it was upsetting. It's upsetting to the family. You could tell how upset he was, and then, he had to have a sitter with him and stuff. So, you really have to have yourself be engaged in the process and have a family member be engaged, because it's scary when you go in the hospital.
There's professionals now too that you can call if you, don't have a relative or whatever. There's
Yeah.
places that you can call and they will meet you at the hospital.
Yeah, it's a scary process. It's so much information. Like you feel bad for people, and now with a lot of the, what we call Obamacare and healthcare initiatives, like you said, you get the big massive packet at discharge, like everyone's
true.
going to read it.
Yeah.
But that's a lot of the Obamacare. That's a lot of the initiatives that came about that we need to provide. We must provide to you. We can't not provide to you at discharge all that information. So that's part of government regulations. So then in turn, we kill a few more trees and provide you a lot of information. You're trying to muddle your way through all this stuff, and it's difficult. So.
Yep.
Funding for Simsbury Community Television is provided in part by contributions from viewers like you. Thank you.